Okay, it's 7:02 and welcome to tonight's webinar, everyone. We've still got people trickling in, but we might as well start. So welcome evening. Welcome to you all. I'm delighted to introduce tonight's British Pain Society webinar, hosted by the Expert Patient and Carer Committee. We've obviously got a few things we want to tell you tonight. So the BPS is the UK's oldest and largest multidisciplinary organisation focused on pain. We're a vibrant community of professionals from across health, research and social care, working collaboratively with people living with pain. The BPS champions person-centred approaches to pain care, advocate for better support and services with policymakers. And we're committed to advancing education through training and evidence-based guidelines. We also promote vital research to improve how we understand, prevent and treat pain, all with the aim of delivering safer and more effective care across the United Kingdom. And we do hope to see you at the BPS 58th annual scientific meeting, which is coming up on the 3rd to the 5th of June. But if you haven't registered, there's still time to register. So we do hope to see you there in Wales. Tonight, we've got some housekeeping rules for you. Please do type your questions into the Q&A chat box, which you'll find in your Zoom control panel. Tonight's webinar is being recorded and it will be available on the British Pain Society's YouTube channel, and you will receive a link for this. Please complete the evaluation form to claim your certificate of attendance. Again, you will receive a link for this by email. So to receive that certificate, you will need to complete that attendance form. So without further ado, I will introduce you to tonight's speakers. Tonight we have three amazing speakers. We've got Tim Atkinson, the Vice Chair of the Expert Patient and Carer Committee. We have Professor Sam Ahmedzai, who is the Professor Emeritus at the University of Sheffield. And finally, we've got Dr. Kirsty Bannister, who is the Associate Professor of Pain Neuroscience at Imperial College London. So tonight, the first speaker is going to be Tim Atkinson. A little bit more about Tim. So Tim is our Vice Chair of the British Pain Society's Expert Patient and Carer Committee, which he's also a lived experience trainer with Live Well with Pain, as well as the founder contributor to Connect Health Flipping Pain campaign. He's also a trustee of Pain Concern and a patient rep to the Physio Pain Association. His memoir about life with chronic pain, Where Does It Hurt?, was published in 2021 and describes with humour and candour his own self-management journey. So don't forget to head over on Amazon and get that book. It's fantastic. Anyway, bit of a... So Tim, over to you.
Thank you, Victoria. Thank you for the plug. That was very kind. Hopefully, in a moment, you can all see my screen. Is that okay? Has that come up? Yeah, brilliant. Okay, well, I'm just going to begin with a bit of an introduction then, really, to the role of the patient voice, as it were, and some specifics about the EPCC as embedded within the BPS. I mean, to begin with, I can just state the obvious, which is that lived experience, in a way, has become, over the last few years, something of a byword for authenticity and credibility. And there aren't really any self-respecting organisations or associations that can afford to ignore, or that should, or that even would want to ignore the patient voice. Because without it, the patient, carer, consumer, customer, or however you choose to describe those of us at the receiving end of healthcare, very little of any benefit can be achieved. There is still a danger, though, sometimes, that it can at times be little more than paying lip service to good practice, or a rubber stamp approval for what the experts say, which is odd when you think about it, because whatever the objective scientific measures people use, and whatever the results of their double-blind trials or whatever the outcome of countless experiments and a lifetime scientific research, it's really the subjective effect of something on a person, a human, on your patient, that ultimately matters most. Why else is anyone in the game? Thankfully, the patient voice is now fully embedded in the work of the BPS, most significantly through the work of the Expert Patient and Carer Committee, the EPCC. And I think it's fair to say that in recent years, thanks to the support of President Professor Roger Naggs and Executive Director Joe Brown, and the tireless work of the committee under the chairmanship of Victoria Abbott-Fleming, what we've done is begun to play a significant role in helping the BPS achieve its aims. So, who are we? Well, we fall into two distinct categories. Membership of the committee covers a wide range, both of professional and lived experience members, and the professional members bring clinical and academic expertise to the committee and are an integral part of our work and overall purpose. The lay members, the lived experience members, on the other hand, come with first-hand experience of a wide variety of conditions and circumstances. We have lived experience of pain in a huge, broad range of manifestations, whether that's as patients ourselves or as carers. There are people on the committee, for example, with arthritis, both in degenerative and immunological forms. There are people with fibromyalgia, complex regional pain syndrome, Ehlers-Danlos syndrome, post-surgical pain, and pain resulting from injuries. So we represent a very broad cross-section of the pain community. And in addition, the lay members have extensive involvement in a wide range of pain management programs. And increasingly, we have a wide range of experience in self-management training. Within the committee, we actually created recently the role of a forces champion to advocate for the particular needs of those in the armed services. The next two slides sum up fairly simply our purpose and our aims. And I'm not going to read them because there's nothing really there that should surprise anybody. But it's important to know that these are things that have been planned and thought through carefully and are now embedded not only in our work, driving what we do, informing our meeting agendas and our projects and the achievements that the things we achieve, I should say. But they're also integral to the wider work of the BPS. So we offer the BPS membership access to ourselves, to people with that first-hand lived experience, as well as providing a lived experience perspective across a wide variety of different initiatives. The specific aims of the committee, again, I won't go through and read that. I'll leave it on the screen for a moment for people to just briefly skim. But perhaps the third is one that is worth just elaborating on a little, to provide a lived experience perspective and contribution to BPS activities and an overview of national self-management programs, because that's where we really come into our own, I think, because these are just some of the organizations that members of the EPCC represent, whether that's formally or informally. And that has the potential to make the EPCC, and in turn, therefore, the BPS, the hub, I think, of a very, very important national wheel. What we all have in common, in spite of those disparate interests and that broad range of experience, is a desire to communicate that experience with the aim of helping others, whether they're healthcare professionals or fellow patients. And that's testified, I think, by the fact that EPCC members have founded charities, written books, started local pain cafes, run training courses, conducted surveys, like the one that Sam is going to speak about later in this session. We've been cited as contributors to research papers. We've delivered speeches at national conferences and much, much more. As Churchill once said, if you want something done, ask a busy man or woman. And I think that's amply testified by the amount of work done by members of the committee. What we are is a growing community which is dedicated to improving pain management, research, and advocacy. And to that end, one of our most recent achievements has been the relaunch of what used to be known as the Patient Reference Group. That's now rebranded as the Lived Experience Collective, which we're hoping over time, which is already becoming a growing database of people with all kinds of different experiences who volunteer to give their time, give their views, to help in whatever way they can, completing surveys, answering questions, maybe participating in research, maybe asking, being interviewed directly about their experience in a way that we hope will cover a wider breadth of the pain population as a whole. And there are challenges ahead. I mean, we are aware that there are demographic and geographic areas that are underrepresented, and this is one of the things that we're constantly striving hard to achieve. We need, with the Lived Experience Collective, to hopefully attain a broad diversity and range of views, and we've gone some way towards doing that with recent recruitment drives to the committee itself, and hopefully with membership of the LEC. I think, just to sum up, because I'm not going to say too much more, I think it's fair to say that the EPC is now, without doubt, a dynamic, a flexible, and a versatile group of patients and professionals. And we're all united by a desire to help the British Pain Society achieve its stated aim of doing more for people in pain. And our work on a day-to-day basis is now fully integrated into the wider BPS remit. And together, as the strapline of the BPS has it, we can do more for people in pain. Thank you.
Thanks, Tim. If anybody's got any questions, please do put them in the Q&A box. But we do have a question for you. How can someone join the EPIC committee, EPCC?
Right, good question. It's by application only. I mean, the committee consists of a set number of individuals, and recruitment takes place as and when there are vacancies that need to be filled, and they'll be advertised on the British Pain Society's website as and when vacancies occur. And I'm about to say, I mean, it's quite a rigorous process. I mean, given that it's entirely voluntary, the BPS does a grand job of making sure, I suppose I would say that, wouldn't I? But of making sure people who sit on that committee are as well qualified in a wide variety of different areas and have a broad skill set as possible. I went through quite a rigorous application process and an interview, the like of which was slightly more exacting than some interviews I've had for paid roles. So I can guarantee from personal experience that the people that you get are usually the best, or the people at least with the time and talent to make the best contribution.
Thanks, Tim. I agree, it is a rigorous process completely with that. How you mentioned about the Lived Experience Collective, how does someone join the Lived Experience Collective? Is there any guidelines, restrictions?
Yep. Again, the go-to place, and maybe we can put a link in the In fact, it's already been put in the chat by Joe. Learn about the Lived Experience Collective. There's a link there. The go-to place is the website. But basically, unlike the committee itself, the EPCC committee, that's open to everybody. And we do want to cast that net as wide as it can possibly be cast, because we are aware that there are regions geographically and there are constituencies demographically who are woefully underrepresented. Their views, they are pain patients, like the rest of us, but their views, for all sorts of reasons, cultural reasons, geographical reasons, are woefully underrepresented. And we're very, very keen that we make the LEC as accessible as possible. So it's a very straightforward process of basically going on the website and filling in your details and volunteering to be contacted on an ad hoc basis as and when people have needs that match your particular skills and experiences, obviously.
Great. Thanks, Tim. And yes, the link is in the chat. We have had another question for you. Are there researchers that represent both sides, i.e. lived experience and research career?
Careers, I'm not at all sure of. I mean, I'm not an academic, and although I have worked jointly with academics on certain research papers, I don't think lived experience is a career option particularly. But certainly all the roles that I've undertaken have been voluntary and unpaid, and I think that's pretty well the case across the board. Have I understood the question correctly? Was that word career at the end that threw me a little bit about that one, Victoria?
Yeah, we're just trying to find that out at the moment.
Okay.
But in terms of EPIC itself, we normally don't accept those that are in healthcare. They're not practicing healthcare professionals. The professionals that we have on the panel or on the committee are also members of the council, and I think they're members of BPS as well. Natalia's actually online now. Natalia, would you like to maybe give you a bit more info?
To clarify, what I meant is, are there any members who are active in research, as in work in academia research, and have a chronic pain condition to offer lived experience perspective into ongoing research?
In EPIC, the answer is no, because we don't have lived experience and professionals at the same time. We just don't accept them.
One of the lay members, sorry to cut across, Victoria. None of the lay members, none of the in inverted commas lived experience members have that professional expertise and capacity. That is a bar really in applying for that particular role. But of course, our professional members can and do have their own personal lived experience to bring to bear. But that is obviously a matter for them, and in many cases personal to their situation. But no, so I think that's a yes and no answer, Natalia. Is it? Has that clarified the answer for you?
A bit, yes. Thank you.
Okay.
Yeah, one of our professional members is an academic researcher. She just doesn't have lived experience of living with chronic pain. And as Tim said, that's one of our bars for the EPIC committee. However, for the Lived Experience Collective, you can be both. You can be someone in healthcare and a researcher, and also lived experience. Hopefully that answers.
Yes, thank you, Victoria. Thank you.
Thanks. Okay, thank you, Tim, for that, and sorry for all the questions. So we're going to move on now to our next speaker, and our next speaker is Professor Sam Ahmedzai. Sam is a specialist in palliative medicine for over 40 years, 30 years as consultant physician before retirement from clinical practice. Professor Emeritus of Supportive Care in Cancer and Chronic Conditions at the University of Sheffield. Research has focused on the assessment of quality of life and the needs of people with advancing disease, pain management, and side effects of opioids. previously British Pain Society Council member, and recently awarded honorary membership for services to pain. And I'd just like to say congratulations, Sam, as well. Over to you.
Thank you very much, Victoria, and good evening, everybody. I really appreciate so many people joining this webinar. I'd like to get my slides. We did it a few minutes ago in the practice. No, not that one. Where has it got to? So just talk amongst yourselves for a moment. I can see it. Why can't you?
Are you okay, Sam? Do you want us to?
Well, it worked just a few minutes ago, didn't it, when we practiced? So where is it?
Did.
Entire, not the entire screen.
I think Jo's got it on her laptop, her screen, if you want her to share it.
Let's just see a second. I mean, there it is. It was at the very bottom. I didn't scroll down far enough. Okay, so can I just check if you can see that now?
Yes, we can. If you want to change it to slideshare, perfect. All good.
Great. Okay, thank you. And can I just check you can hear me all right?
Yeah, all good.
Thank you very much. So following on from Victoria's introduction and Tim's a very helpful overview of what the committees do, the Patient Expert Committee and the Lived Experience Collective, I'm going to talk about something practical that we've done. And actually, over the last couple of years, even before these two committees with those names had existed. So they were done with a previous committee called the Patient Voice Committee. So you'll see that on my slides. And that was because these surveys were carried out by essentially the same people, pretty much the same people who are on the present committees you've just heard about, but it was done under a different name. So, and these two surveys were asking basically, how can we tap into the lived experience of people living with chronic pain? And you've heard about why that's so important to us in this work. So basically, there have been two surveys. Actually, there were three. I'm not going to talk about the first one. That was back in 2020, where the then patient committee had a role. I'm going to talk about a survey carried out in 2022 and another survey carried out in 2024. Now, both of these are published in the British Journal of Pain, and there's the reference for them, where these are the published abstracts for the presentation at the scientific conference last year. Now, I must have a warning here. What I'm presenting is not research. It's not clinical research. It's not scientific research. These are surveys because they're done using members of the public, and it's totally anonymous. We couldn't control who was taking part. So we have all those limitations of doing this kind of public surveys. So we can't pretend that these are research studies. So the first one published we did in 2022, it's called a National Survey of the British Public on Experiences of Living with Persistent Pain. And it was a co-production between the patient representatives on, as you can see in the top corner there, I've got the logo for the old committee called the Patient Voice Committee, but now EPIC. And these are the people who are on that committee, and also some professionals from the British Pain Society. The aims of that survey were to try and build a picture of how persistent pain affects the spectrum of the British population, to understand the issues that they are having in accessing help and services, both in primary and secondary care, and to learn how self-management has formed part of people's approach to living with chronic pain. So basically, this was a questionnaire which was co-designed by the patient members and the TPVC then, and healthcare professionals. We went through several rounds of refinement and testing. We treated it as if it was research very rigorously. And then we ran it out using SurveyMonkey, which is a commonly used survey format. The final version was disseminated through the BPS website, through our newsletter, and our social media, mainly Twitter and Facebook. And we had the survey open for 2 months. Now, the data set of responses was shared then between British Pain Society professional members who are used to analysing numbers and surveys, but also qualitative data as well. So we had professionals helping with both those sets of analyses. So from that survey, there were 825 people who responded, and the vast majority completed the survey themselves. 3/4 were aged between 36 and 65, but you can see there that there were some in the younger age group and some older. 79% identified themselves as female, and 89% were white British. 3/4 of our respondents lived in England, but there was 25% coming from other UK countries. The types of pain these patients were experiencing was quite wide. Fibromyalgia formed the largest group, 47%, musculoskeletal pains, 40%, neuropathic pain, 33%, complex regional pain syndrome, nearly 30% as well, and then smaller numbers of headache, orofacial pain, visceral pain, and cancer pain. One of the opening questions we asked them is that, who has helped you with your chronic pain? The commonest sources of help were GPs, 88%, physiotherapists, 66%, and rheumatologists, 42%. Now, we asked about access to pain clinics. The first one is, how long did it take you from the onset of your pain to referral? Now, by the way, 70% had been referred to a pain clinic, mostly by their GPs. Over half had waited over a year. And you can see that there were some who actually were referred within the first 12 months, but then people were also waiting 1 to 2 years, and 30% waited more than 5 years. How long did it take from the date of your referral to being seen in the pain clinic? And again, majority was seen within the first 6, 9, 12 months, but there were some patients were actually still waiting 3, 4 years after being referred before they got seen. Now, how do you get to your clinic? 53% had to travel up to 10 miles to be seen at their pain clinic. 12% had to travel over 40 miles. So an issue of distance. We asked, who would you normally contact if you needed help with your pain during usual working hours? And the commonest source of help was GPs, 51%. 1/3 said nobody. 30% used a family member. 13% used a friend. We then said, who would you normally contact if you needed help outside of usual working hours? Family members, top of the list, 35%, dialing 111, 24%, a quarter, phone a friend, 16%, and pop into A&E, 13%. So we asked the question also, have you ever attended the hospital A&E department because you felt your pain was unmanageable? And 60% said no, but 40%, substantial number, had actually visited A&E because their pain was too much. We asked about self-management, and one question was, have you been taught ways to self-manage your pain by a health professional? Roughly equal numbers said yes and no. But large numbers said, well, partly. They've been given some information, but they've learned it themselves. So 95% of respondents were well aware of what self-management means, but they'd learned about it from a wide range of resources and used many different types of techniques. We asked, have you learned self-management skills yourself without a health professional? And the vast majority said yes, they've had to do it themselves. We asked lots of free text questions as well, not just sort of fixed questions with numbers. So we asked questions, and the themes that came from the free text responses analysed by my colleagues were things like access to services, especially pain clinics and pain management programs, waiting times, travelling issues I've just talked about, effects of the pandemic, because it's a 2022, out of hours access, learning and support for self-management. They volunteered other sources of information that they used. The most frequently cited categories were the internet, either Google or other internet searches, NHS website also, social media and forums, and they use Facebook groups, YouTube, patient forums, and online forums. An issue that kept coming up in the free text was travel. The long journey exacerbated pain. Long waits in the waiting room also exacerbated pain. The appointment was 2 hours long, and I ended up in severe pain from just sitting in my wheelchair for that time. Another theme was not being listened to. Frustration with medical professionals who do not listen to my patient voice. Doctors not listening to my needs, but not taking the time necessary to understand my condition, Ehlers-Danlos syndrome in this case. And then they volunteered suggestions of how patients and public can help. For instance, how to make my GP take my pain seriously and discuss medication change. More information about communication between providers, more awareness from healthcare professionals about CPRS particularly, and seminars for ward nurses, regular reviews with pain team to support, and being listened to and believed. Now, looking back at that survey, the strengths is that it gave us a good picture of the main issues affecting the pain patients, including long referral times to access the clinic, long distance to travel to get to them, and lack of understanding or education about pain conditions. Also, better understanding of how self-management is being supported and used by patients, pain patients and their families. Weaknesses include we had no control over who got the survey and who responded. This was not as I said, a research program where we could control that. So we couldn't also control the representativeness of the sample. I said the most came from England, actually most came from the southeast of England. We couldn't make it totally representative because of the nature of the survey. So we need more coverage of different age groups, much more of ethnic minorities and other UK countries and regions. So switching to the next survey, which we conducted in 2024, this is called a National Survey of British Public on Experiences of Living with Persistent Pain, follow-on survey on medicines prescribed for pain. So this was basically a follow-on to the previous one, using initially the same sample of responders. Sorry, the people named there are the ones who were involved in this survey, slightly different from the first one. So the follow-on survey used the same sample as 2022, and we have to acknowledge that the idea for this came to us from Channel 5 Health News, because they got in touch with us, they'd heard about what we'd done before, and they said, well, actually, there are other questions that we'd like to know about. Could you ask your patient group to tell us about the medicines they've used? Now, that was on our horizon, but we actually then said, right, let's do it. So we worked with the Channel 5 producer to make a new survey using the same sample as before, but focusing just on prescribed pain medicines. These were prescribed ones, not over-the-counter ones. From the original 800 survey responders, 400 odd had said, yes, they'd take part in further surveys. And then we actually had a lower number who only gave us their emails. We then got 225 responders, which was a 50% response rate, much smaller than the first sample. Again, we couldn't control that. Demographically, the distribution was the same, but rather fewer responses from outside England, unfortunately. And we had a higher representation of musculoskeletal disorders and neuropathic pain second time round. Now, the key findings were that 87% of responders were on prescribed pain medicines. These were either opioids, antidepressant types, non-steroidal anti-inflammatories, and oral anti-epileptic drugs. 86% of respondents had taken medicines for over 2 years. Now, 77% of them had experienced benefit, but 67% had experienced side effects from their pain medicines. 69%, over 2/3, had not received any specific information about the risks of taking pain medicines for longer than 3 months. This is something we talk about, but that message hadn't got through to these patients. And the information about the risk from taking pain medicines long-term came, if it did, from doctors, from pharmacists, or from other health professionals. So we asked about, have you had help with reduction of medicines, knowing how important it is to reduce or taper off medicines? the vast majority said they did not receive any offers of help to reduce. And if you experience unpleasant side effects from too rapid reduction or tapering or abruptly stopping medicine, were you offered any help to deal with these? The majority said no. The main themes that we got from the free text was that there was significant benefit from pain medicines. For example, the biologics have given me my life back. Probably a patient with rheumatoid arthritis. Some benefit from pain medicines or takes the edge off. For example, using these medicines helped to reduce my pain to a level that allows me to work part-time. But then there were also some benefits, but with side effects. There were some benefits, but the negatives outweighed them. Another theme was regular pain medicine reviews. One said, I never had a GP pain medication review, but my pharmacist does call me for a review regularly. Absence of regular pain medicine reviews. My last review was about 6 years ago. That said, I'm constantly reviewing my meds and the effects of the same self-management regime. I've not had any offers in the 12 years I've been prescribed them on repeat prescriptions. The key messages coming through was that of particular concern, the majority had been on pain medicines for over 2 years, and most of them had not been warned of the risks of continuing for 3 months or over. Very few had received offers of help to taper their own pain medicines, and most of them who have had them abruptly were not offered any help in dealing with those side effects. Now, overall, in spite of the smaller sample size for Survey 2 and the limitations over controller representatives I've already talked about, both of these surveys show that what was a TPVC, now EPIC, has tapped into a rich stream of information on pain in the British public. And the national media are interested. Channel 5 ran a news item in their main 6 o'clock news using the data from our survey and interviewing some of our BPS colleagues as well. So acknowledgements, I'd like to thank all of those who responded to our surveys. There may be some of those people on the call today. Thank the members of the committees, including I'd like to thank Dr. Helen Bolter, who was a patient member of the TPVC at that time, but she died during the analysis of the survey, the first survey. I'd like to thank the members of the British Pain Society Council and Executive, the secretarial staff who supported us, and also Channel 5 Health News team. Thank you.
Thank you, Sam. A lot of detailed information in there, so it was great to see it all again. We've just got a couple of questions. What surprised you about the results? Was there anything that surprised you about the results?
I think the first thing that surprised us with the first survey was how many people responded. We just put it out there without any idea how many were going to respond. The second survey was lower, and probably we'll use different techniques next time. But I think that the main message coming through, people were being very honest. People felt safe to tell us very personal experiences. I mean, there are pages and pages of those free text responses, and we've tried to I've just summarized them very shortly here, and we're going to be publishing them in a fuller format later on. But it showed that people are willing to talk about their pain experience. We just have to get out there and ask them in a way that they can respond to. And social media and the website seems to be one way of doing it.
Yeah. Will there be an updated survey, do you think, Sam?
I can't commit anyone to it because we haven't totally agreed that yet. But yeah, I think there's so many more themes that we can tap into. So watch this space. I think there well could be.
Is there anything out of the survey that you would like to maybe go into in more depth? Any part of that survey?
You mean just now, or in
yeah, if we did a future update, for a future survey?
Yeah, I think the pain medicines one was interesting, but we only scratched the surface. These were the prescribed medicines. What the patients were aching to tell us, and they did tell us anyway, was the over-the-counter ones and the ones they had accessed in different ways on the internet. So that's a really important thing to tap into. We shied away from this time because we just went for prescription medicines, but I think that's another thing that we need to tap into, because realistically, that's where people are getting medicine from.
Yeah, that's true. If there was another survey, why should people get involved? Why should people take the time to complete the survey?
Because you're actually helping BPS, British Pain Society, to have a greater knowledge of the people that we're actually here to serve. The society is serving the public, the British public, with persistent pain. We need to hear your stories and your experiences. But also, can I just say, next time we do this, we need to hear more from younger people. We had some in their 20s and 30s, older people, but also people from different parts of the United Kingdom and different ethnic groups. We want to really reach out to those. We have to find ways of reaching out to those other audiences.
Yeah, completely agree. Tim, do you want to ask your question, or is
I
there one
was
in the
just
chat
making an
box?
observation, actually, which is relevant to what you and Sam were just discussing, which is that the Lived Experience Collective, of course, has, as part of its relaunch, issued its own mini survey, almost like a customer market research kind of thing, in a dynamic electronic format, which it's hoped can be constantly updated as more and more people join and more data gets added to that. So rather than have a fixed term survey, it's almost hoped that this is going to be a continuous update of all the information from all the people that sign up to that.
Yeah, exactly, and well plugged as well. We have got a question in the chat box. Are there any existing practices or studies in the UK pain management system that focus on supporting patients during long referral wait times to maintain emotional stability and motivation for self-management?
That's a trick. It's a very specific and tricky question. I can't think of any for myself off the top of my head, any specific studies. One thing I should say, though, is that after the pandemic, or during the pandemic, we learned ways of actually reaching out to patient populations quite differently than bringing people in. Obviously we couldn't do that during the pandemic. And I think that we've learned now, and I'd like to think that if we ask that question again now, there would be many people, many fewer people who had to wait so long, because they would have been offered an online appointment, an online support as well. So I think that the ground has shifted after the pandemic. And I think that if we did it now, I think we'll find much more reassuring figures in terms of that waiting time. How people can cope with that waiting time, I'm probably not the right person to ask, because you need to ask people who are actually running the services, of how they give those outreach.
Thanks, Sam. Tim.
Yeah, just going to add about existing studies. As Sam said, I'm not aware of any, but practices in terms of interventions. Some of the work I do, assisting in training programs for healthcare professionals. Most of their interventions in pain management situations are remote anyway, and the training that we're involved in is remote. So people's access to the resources, the standalone resources that they can benefit from without even getting to the point of having an appointment at a pain clinic have mushroomed, have expanded beyond all comprehension since the pandemic, because of course it was driven by that need to make things accessible in a variety of different ways. So there are a number of different practices, Flipping Pain Campaign, Live Well with Pain, just two examples off the top of my head, where people can go direct to the material that healthcare professionals deliver as part of pain management programs.
Yeah, I was just going to mention actually Live Well with Pain and Flipping Pain, and there are various, they're not studies, but there are existing campaigns and organisations. And actually the BPS did do a webinar very recently, a couple of months ago, on what is out there for pain management and self-management. So we will put the link to that video in the chat as well. And obviously you've got people like Pete Moore and the Pain Toolkit, as well as the Physio Pain Association, and various other charities and organisations that support individual conditions as well. I believe there's another question, but I might leave that one to the end, if that's all right, Natalia. Okay, so thank you, Sam, for that. Our next speaker and our final speaker for this evening is Dr. Kirsty Ballister. Kirsty's research team bridges the gap between bench and bedside pain research as they conduct exploratory experiments to define the way pain is modulated in animals and humans, including patient populations. Her funders include the Academy of Medical Sciences, Medical Research Council UK, and Parkinson's UK. No matter the project or funder, Kirsty strongly advocates for patient involvement to strengthen her team's research strategies. So welcome, Kirsty. Over to you.
Thank you, Victoria, and yeah, thank you for having me on the panel with yourself and Sam and Tim. I always learn so much from these interactions, and I'm really grateful to be able to be part of this webinar. Let me share my screen, and Victoria, let me know if you can not hear me or see my slides.
I can hear you and I can see your slides in full slideshow. Thank you.
Thank you. I'm here to tell you that I am a basic scientist. Engaging with patients leads to better fundamental research strategies, and I hope that from the examples I share with you now, you can understand exactly how that works. So if we want to think about what these fundamental research strategies are, we can break them down into three components. We've got basic research, where we might do experiments to understand what causes a disease, what mechanistic underpinnings there are to a disease state. But we can also do translational research. This is another fundamental research strategy where we try and use that biological knowledge that we've gained from our basic research to treat disease. And then, of course, we've also got clinical research, where we're trying to understand whether the treatment strategies we're developing in our basic and translational research are safe and effective. And so in this way, if we try and link those research strategies to pain, we're really talking about a translational arm between all branches in order to better understand what causes pain, how we can measure pain, and how we can treat pain. And I suppose my job today is to convince you that basic scientists like me who work across all three fundamental research strategies very much rely on interactions with patient populations to enhance the research questions that we put forward for funding when we're trying to understand pain in terms of its cause and measurement and treatment in the most optimal way possible. So if we start at the top end then by thinking about how we can work together with patients to improve the way we approach clinical research as basic research scientists, we might think about in the first place how an individual describes their pain. And I'm taking my lead here from the work. I work with various patient groups, but today I'm going to focus on the work we do with patients with Parkinson's disease. And a huge proportion of individuals with Parkinson's live with chronic pain as a major non-motor symptom. And this is just some of the descriptions that patients use in our clinics when we're performing sensory profiling. For example, they might talk about a burning pain that develops progressively, a pain that's in upper aspects and lower limb pain, and overwhelming deep pain within the body. And what you'll notice is that that pain is often poorly localized. They might talk about it being constant or medication linked, be that it's responsive to or not. But also you'll notice that there's lots of different descriptors used in terms of those sensory descriptors, burning, but also affective descriptors like overwhelming. And this reminds us of that definition of pain, which is talking about pain as an emotional and sensory experience, and of course reminds us that pain is so complicated to study because it's much more than a sensory discriminative experience, it's also an affective motivational one. So we understand from listening to the patients describe their pain what I suppose descriptive axes their pain is leaning on, in terms of that definition of pain. But we also need to understand those descriptions of pain to refine the way we're measuring it, and then also how we're phenotyping it. And why we want to do this is because we should really have a standardized approach to pain measurement in our cohorts, so that we can have good confidence when we perform our clinical research in the validity of any observed effects that we see. So this is a really important part as a basic researcher of ensuring that our clinical research is correct, is by listening to the way an individual is describing their pain. So when we think then about those processes of refining pain measurement and phenotyping, again, this is just in the in that domain of Parkinson's that I'm talking about specifically here. We know that there's lots of different pain scales that we can use that split those domains of pain into different categories, and that ultimately, if we look at the severity of that pain type and its frequency, how often a day it's happening, we can create a profile for that individual that allows us to understand what their burden of pain is. And in this way, we're beginning that refinement of the way that we're trying to tackle the problem of pain for this particular patient cohort. So it's all very well to say that we can apply these scales, these questionnaires to measure pain. But of course, we know that one of the big issues is that when we're measuring pain in humans, or when we're asking individuals to talk about their pain experience, that this is an entirely subjective experience. It's a non-linear experience. And of course, if you look at an individual and their injury or their lack of injury, it actually doesn't tell you anything about how much pain that person is experiencing. And of course, there's that very special keynote, if you like, the one that deserves a lot of attention alongside that definition of pain that's released by the International Association for the Study of Pain, that says simply a person's report of pain is to be respected. Okay, but then how can we refine the way then that we're measuring pain if we understand that simply offering an individual visual analog scale to tell us where their level of pain is inadequate? You know, we don't have from this an adequate portrayal of the level of pain an individual's experiencing in any way that can be linked to a pain processing mechanism. And of course, that's the goal for someone like me as a pain neuroscientist, is to link the pain experience to a mechanism, because that's the way in which we can start to think about therapeutic target interventions for optimal pain relief. So we can think about the way we measure pain outside of using the visual analog scale by applying quantitative sensory testing. And this is something we do in my lab, where we're basically trying to understand how an individual tolerates pain and how that tolerance changes when different aspects of the pain state change. So really all that I'm showing you in this diagram is that we can apply these different paradigms. For example, here we've got pressure cuffs, which are akin to a blood pressure cuff around the legs of an individual, and we can inflate that cuff to noxious pressures and understand how an individual's perception of that pain changes when you apply a second noxious stimulation. And what you can see in the top graph here, if I just put my I'll put my laser pointer on. Let's see. No, I don't want to draw. I'll turn that off and start again. Yeah. So you can see that an individual's perception of their pain shifts towards a lower pain rating at a higher pressure when we apply these two noxious stimuli, for example. And what this is allowing us to do is understand how well an individual's central modulatory processing pain processing pathways are working. But what's important is that we have a method by which we can translate this exact paradigm to animals, and we can perform in vivo electrophysiological processes that allows us to obtain spinal neuronal correlates for human perceptual outcomes. This is an entirely translatable way of understanding pain in humans and how pain perception can change when we introduce different noxious stimuli, and back translating that paradigm to the bench, to the animal domain, where we can use the exact same paradigm within a carefully designed protocol to get a spinal neuronal correlate, for example, for that perceptual outcome. And in this way, by applying the host of bending force bending forces and pressures and pinprick stimuli to our animals performing these electrophysiological experiments, we can get actually neuronal readouts for the whole gamut of quantitative sensory testing, both static and dynamic tests that we might apply. So I want you to bear that in mind now when I talk about that basic research, which was right at the start of those fundamental strategies we use to understand pain states in terms of what causes disease. So this is now all about mechanistic underpinning. And we used those strategies that I just showed you, where we back translated the paradigms from the human domain to essentially dissect a circuit which was otherwise unknown. And this is a naturally occurring pain inhibitory circuit. This is one that we all hope we have functional in our body, but one that isn't pharmacotherapeutically targeted, simply because the circuit of the function of the circuit wasn't known. This happens to be a circuit that is entirely driven by noradrenaline. And this translates very well back to the patient domain, because we know that there is an originergic subtype of Parkinson's disease, and we're applying these tests both in animals and humans to understand, really from animal models to clinical practice, how this impacts patients and how it can affect the circuits that we're trying to dissect in our animal models. So in this way, then, we can start to understand better through circuit dissection, when patients are talking about the pain types, how that is linked to a mechanism and therefore a therapeutic target. So there's this whole host of neuropathological studies that combine neuroimaging and animal data that suggest there's a predominant noradrenergic dysfunction-driven phenotype in Parkinson's cohorts. And if we can formally identify this clinical subtype, we can then better define the progression, the maintenance, and the development of these subtype-specific personalised treatment paradigms. So all of this type of research is born from understanding how we can better measure pain in humans, which is all underpinned by the researcher spending a lot of time with the expert patient groups to understand what types of pain are important to them and what questions are important to them, and then back translating those paradigms to the animal domain, where we can obtain those neuronal correlates of what the humans are telling us that the perceptual outcomes are. So I want to just give two examples of how we're putting this into practice. Based on all of that background information I just gave you, where we're looking at those fundamental research strategies, which completely entwines what the patient voice is telling us and what the basic science techniques can allow in terms of circuit dissection. And this project was to investigate that link between major motor and non-motor symptoms in Parkinson's and sensory processing, where we had a key question regarding what the functional overlap between neurodegeneration and pain was. And so we relied on a combination of two groups, a clinical group and a basic science group. This was led by me. This is my Parkinson's UK study, and a huge contribution from CRISP, the Community of Research Involvement and Support in Parkinson's, who were able to talk to us about what was important to them, what variables they would like us to capture when we're carrying out these tests. And so we were collecting data on symptoms, including akinesia, sleep, and mood, using questionnaires specifically to probe motor and autonomic dysfunction. And we were using our translatable paradigms on sensory processing exactly along the lines that I just showed you, these paradigms that we can switch between bench, where we're really digging into what the circuits are that mechanistically underpin that pain, and bedside, where we can apply these tests to patients to understand how they process innocuous and innocuous stimuli, to really produce a sensory profile that tells us something about the type of pain these individuals are experiencing. And, you know, what we've found, and this paper is now ready to go, it's ready for submission, is that those patients with Parkinson's who have severe pain experience a significantly increased burden of motor and non-motor symptoms. Perhaps that's unsurprising. And that naturally occurring pain inhibition that we're so easily and readily able to translate and measure between humans and animals is dysfunctional in a really high proportion of individuals with Parkinson's compared to healthy controls. But that surprisingly, this dysfunction in pain modulation doesn't correlate with overall pain burden or any other of the motor or non-motor symptom assessments. And so in this way, we can say we've got an association between Parkinson's and dysfunctional sensory processing, even in the absence of chronic pain. And we're now going to back translate these findings to improve the models we're using when we investigate Parkinson's, and also try and understand better what the mechanistic link between these circuits that drive sensory processing and neuronal degeneration are. And this is something that we've just spoken about really recently in terms of the pathophysiology of pain in Parkinson's in a recent Lancet review. We also want to understand better, and this is the second part of our project. We went to our expert panel group, and you know, they know about this project, we know about the data, and we asked them what was important to them, what should come next. And actually what is really important to our patients are the biopsychosocial factors that are associated with their pain. So we want to innovate this assessment so that we can have an integrative understanding of the factors that contribute to the experience of impact of pain, where we want to really understand, is there a clinical utility of daily monitoring when we're informing behaviour change in future pain management interventions? And we use an ecological momentary assessment for this so that individuals can give us data in their home environment. And we spent a good 4 months with our expert patient group last summer so that we could refine how many questionnaires a day these individuals are willing to take, how many questions per questionnaire, how many days they would complete that data collection for, what the relevance of the measures might be, and final item selection and wording. And where we ended up was in a series of questions which, only because of that patient input, we can understand from a basic research point of view what we need to be looking for when we're trying to understand pain better in this cohort. So this is work that's ongoing. I'm working closely with Whitney Scott and Zara Raymond on this to really understand how we can bring together these psychological aspects with sensory ones as well. And so hopefully I have convinced you that patients, we need to work with patients as basic research scientists to influence research strategy. And I just want to end by outlining this paper that we published a few years ago, which was really talking about what these challenges are in translational pain research, where actually what we showed is that research will only exist across axes that use laboratory animal to humans, both experimental and patients, and biological systems, so somatosensory to psychological. And we can't miss any of those factors if we want to really understand what pain is, what it's mechanistically underpinned by, and how we can treat it best. Thank you.
Thanks, Kirsty. Really interesting once again. Couple of questions for you. What's the applicability of the scales, do you think?
The applicability to other patient groups, for example.
Yeah,
I mean, so what we find, one of the other groups we work with include individuals with inflammatory arthritis, and we find that what's important to those individuals in terms of the variables we might want to explore alongside the quantitative sensory testing can really look quite different. And so with any one patient group, you might want to understand whether for them neurodiversity is of importance, gender considerations, affective disorders like depression, anxiety. So it does change according to the patient population, but what doesn't change is that we're really trying to tailor these sensory profile processes to a patient group based on what they deem is important. And certainly with the last study that I showed you, all of the information around what questions we should be asking about stigma and social support and effect, all of that came from our patient inputs, because you know we need them to tell us what is important to them. So it's completely transferable across pain states. You just have to start from scratch each time to make sure that you're capturing the correct variables.
Okay, thanks. Pete has asked in the Q&A box, when researchers publish their research, would it be possible to also publish layperson's versions?
That's a really interesting question, because as you'll all know, when we submit our research grants, we always have to submit a lay summary. So that's something that we have no option but to do. With the journals we typically publish in, again, you probably already aware of this, there's very strict word count limits. You know, you typically have 250 words for your abstract, 500 words for your introduction, 1500 words for your discussion. And so I think what we would need is a push towards an extra 300 words maybe for that lay summary, in terms of what the research question was, what the aim was, what the outcomes were, and whether we answered that research question or how we answered the question. Of course, words are money. And, you know, with every journal, every half a page counts. And so that's something that will rely on a change across the sector, unless they're going to take words away from the research findings to give words for a lay summary. So I like that idea. We do it already with grant applications. I just don't know in practice how it would work in publication, just for financial reasons, if nothing else.
Yeah, I completely understand where you're coming from. Sam.
Yeah, thanks. That's a good question and a very good answer as well, Kirsty. I just think the other thing that can be done now to try and make research results more presentable, understandable, is by presenting them in the form of infographics. Now, this is quite a new trend. I'm not very good at it, which is why I didn't use them in my presentation. I thought, looking back at some of my slides could have been presented much better in a nice, clean, modern infographic. And there are tools out there now available. So one of the things that I'm seeing now with lots of medical scientific publications is at the end is a small infographic summarizing the key points, which is like a take-home message, which is assimilated by members of the public as well.
Yeah, no, I mean, it's a great idea. And again, I suppose it also depends on the study. I mean, some of the studies that we're involved in are really actually not to do necessarily with chronic pain. They're just about trying to understand the basic physiology of nociception. And so I suppose it depends on what the aim of the project was and what you're trying to answer. But I agree, across the board, regardless of whether this is just basic physiology of nociception or trying to do something that's targeted to a therapeutic outcome, infographics are always the way to go. But as you say, some of us are a bit more dinosaur with our computer literacy, and so perhaps shy away from it, because where do you begin?
Not that much of a dinosaur, I'm sure. Yeah. Actually, this question Tim did answer, but just getting your perspective as well. From a basic science perspective, is there evidence that early emotional distress, such as fear, helplessness, or uncertainty, has measurable effects on how chronic pain develops or persists in the brain?
Yeah, I mean, there's lots of early life neonatal animal research out there that shows that, you know, early interventions, surgical procedures, etc. Or, for example, pups who are taken away from their mothers before they've finished weaning. So that's obviously a different kind of stressor. Have altered circuitry profiles, if you like, in terms of nociception, so that neural process of encoding a noxious stimulus. So there's lots of data on that out there in the literature. Rebecca Slater's done a lot of work on that, so is Mariah Fitzgerald, and gosh, many others who later I'll think, oh, I can't believe I didn't name them. So certainly in the preclinical world, that's something that's been studied a lot, and we definitely know that there is an impact. We did some work in humans, looking at how, you know, the impact of adverse childhood events on how individuals in adolescence perceive pain, and that can be linked in a very complicated way to self-harm, for example. So those kinds of studies are really important, and they're out there, and they can help us understand who develops that vulnerability to go on to develop a chronic pain state. That's one of our big goals, is you know, understanding what that preloading vulnerability looks like and who has it. And we can get that information from studying not only the people who have developed chronic pain, but also by looking at individuals who've had those early life stresses and haven't gone on to develop chronic pain. Why haven't they? What was their protective factor? So that's something that is really interesting and that we need to do a lot more research on.
Yeah, definitely interesting as to the comparatives between the two groups as well. Sam.
Yeah, if I may ask a question, just following up from that answer, Kirsty. Yeah, understanding who your patient is, in my case, because I'm a clinical doctor, or who your, let's say, your test animal might be in the laboratory. One of the factors which I think for many years was hardly thought about, and certainly in human medicine, we never really thought about it until quite recently, is the differences between men and women. And, to be honest, a lot of the studies were just done on men, for instance, not really thinking, that women were different. But we understand, obviously, not just that they look different, but they function differently and they respond differently to lots of different stimuli. How is it in the laboratory? How much allowance do you need to make for whether you're working with male animals, female animals, and what influence does the sex have on this kind of things that you're measuring?
Yeah, so I mean, I would say for the last 2 or 3 years, UKRI have insisted on all experiments being performed in equal numbers of male and female animals. So we definitely circumnavigate much better now any issue with only looking at males, because traditionally the studies were all done in males. If you took at a rat, it was going to be a sprog dolly and it was going to be a male one. We can't get away with that now. We have to have equal numbers of both, which allows us to understand whether there's a sex difference. It's important that we're powered to detect what those sex differences might be. And I think it changes according to the model. I mean, in our lab, for example, we have a rodent model of cancer-induced bone pain, and we find that even under the precise same experimental conditions, the tumor progression is different in the female animals than it is in the males. And so those are the kinds of things that we can start to tease apart. But it doesn't happen in every model, and we don't do every model in my lab, obviously. And a lot of that basic pain processing physiology isn't different between the male and the female animals. So it really depends what model you're looking at and what particulars of that model you might be studying too.
Really interesting. I think at the moment there's so much going on in research that we just, it's really, really interesting going forward, I think. So thank you to all our speakers this evening. We've still got about 15 minutes left. So please do feel free to unmute or ask a question in the Q&A. Please do ask, that's what we're here for. I know that we've got a couple of questions if nobody has any. Tim, question for you. What's it like being on the EPIC committee?
Oh, what's it like being on the EPIC? It's absolutely wonderful. And I can say that with my hand on my heart, because there, with total candor, have been times in my 3-4 years of being on the committee when that hasn't always been the case. But I really do feel that we've grasped the nettle. We're totally on board with the BPS, and our values and aims and objectives align, and we're getting the support to do what we need to do best and provide the specialists, be they clinicians or academics, with as much practical help as we possibly can. There's never a dull moment. It's a really, really varied role. We could go from, long discussions on things like the patient survey that happened a few years ago to very quick decisions about getting some information campaign out there, getting a leaflet produced for people on something, or getting a bit of video content up on the website. There's a great group of people, and when you need ideas, they really do come up with the goods. It's very stimulating. I learn as much I gain from it in terms of learning from what other people have to say and their approach to things as I contribute.
Great. Thanks for the honesty, Tim. Sam.
Yeah, if I could just add to that. I mean, I've been working with patient groups for 40 years since I first got involved in cancer research, before the mists of time. And it used to be that our patient groups were not just lip service, but we just gave them specific questions and then that was it. They were not actually allowed to voice their own feelings about things. They were just there as a sounding box. It's changing now, and I see that changing very much within the BPS as well. In that, for instance, the things that you're talking about, Tim, it's patient-led. It's your agenda. It's coming from people living with the pain rather than scientists or clinical researchers like me saying, I want to do this study. What do you think about this questionnaire? Well, actually, you might come back and say, well, you're actually asking the wrong questions. You're not asking what really affects me. And this is the kind of thing that we've just been hearing that Kirsty's doing, patients with Parkinson's disease. You have to know how pain affects their lives as opposed to somebody with cancer or chronic arthritis, for instance. It's different. We can't just assume it's all the same. So what's really good about working with the BPS patient committees is that you're holding the reins. You've got the control of the agenda.
Yeah, and it's a two-way process though, Sam, as well, isn't it? It's very much an agenda that's informed by the clinical and the academic needs. And as patients, we have occasionally it's felt like the tail has been wagging the dog, but it's very much more now a partnership of equals, which is pretty well exactly as it should be, I think.
Got some questions now in the Q&A chat box. First question, as a designer exploring how to better support chronic back pain patients during long wait times or emotionally uncertain stages, the person is wondering, number one, given the emotional impacts of chronic back pain, is there any evidence or practice supporting the inclusion of emotional screening and or psychological support at the first point of care? Okay, none of us are frozen, I don't think. Just checking.
So sorry, Victoria, would you just
repeat the question?
Clarify what the question was there, because
I think that they're asking, is there any evidence or practice supporting the inclusion of emotional screening and or psychological support at the first point of care?
Right. Speaking for somebody who's working mainly in the cancer world and some other chronic conditions, I think we now recognize that, the first contact with the patient, whether it's in the clinic or online now, as I said, many more contacts are online now, is actually learning where the patient's coming from. Often what we do is that before we actually see a patient in clinic, for instance, we might send them a questionnaire. And that questionnaire could be something like the brief pain inventory, which is asking about pain, but it asks about impact that it's having on your life, everything from sleeping, working, activity, etc. So we don't actually engage with a patient with pain unless we know how it's affecting their life. We shouldn't do anyway. I mean, sometimes we don't have the time to do that. So pre-screening questionnaires before patients make contact with health clinicians, but also during the course of treatment, asking not just, is your pain improving, but actually, has your life improved? Or, as often we find, pain is improved, but the side effects are actually have a negative impact on quality of life. We have to know those things. So yeah, we need to find out how the pain and also the treatments are affecting the patient's emotional state.
I think just to add from a general kind of self-management point of view as well, of course, the emotional impact of all sorts of factors, socioeconomic factors, psychological factors on chronic pain is now well understood by patients who've undergone pain self-management programs, patients who have self-educated in that regard or been fortunate enough to go to face-to-face pain clinic sessions. I think the paradigm now is very much the biopsychosocial model, which doesn't see pain as just simply noxious stimulation, but as embedded within a holistic experience. And interestingly, the second part of the question is about integrating cultural medical systems, such as sort of traditional. As part of my role on the EPIC committee, I also sit on the philosophy and ethics special interest group as part of the BPS, and they have very much become open to all the cultural medical systems that the questioner refers to. Initially as just as discussion points, but with specialist speakers advocating for different medical models at different events like this, different webinars, for example. So it's very much something that is on a broader BPS agenda, shall I say?
Yeah, agreed. And just to go, so the question is out there for everyone. In BPS research or practice, what's the current stance on integrating cultural medical systems, such as traditional Chinese medicine, into chronic back pain management, and what are the potential barriers or opportunities for collaboration? Sam.
I don't have an answer about Chinese traditional medicine, I'm afraid, but another thought that comes to my mind is that this may have come through after the pandemic, but I think it was happening anyway, is the rise of virtual reality in creating environments in which patients can explore, not just their physical feelings, but also their emotional feelings as well. And virtual reality systems are being used in lots of stressful situations, for instance, during cancer treatment, I'm aware of, but also, I know Pete Raw, who's on the call, also is interested in virtual reality as a way of people, self-managing their pain as well. I think that's an area that we need to watch, because that could really go somewhere.
Yeah. Joe.
Hi everyone. I don't normally jump in on these Q&As, but my name's Jo Brown and I'm the Executive Director of the BPS, and I just thought I would jump in on this question. The BPS does recognise, pain is such a complex condition, and what we do support is a multidisciplinary and evidence-informed approach for whatever that care would be. So we really encourage research into these, complementary traditional modalities. And we do know that some of the people that we interact with, this works well for them. So we would never be against something that works well for a patient. We also realise how difficult it can be to have research that's, robust on these therapies. So, when that, the more research, the better. But if that's something that works for you, then we wouldn't be against that. We would just encourage that we can try and find more ways to do that research and make it more available. I think there was some barriers, right? And I think the evidence-based scientific rigor is a huge barrier. We have the philosophy and ethics special interest group, which Tim is also a part of, and we have these discussions. And I think that's the thing with pain. There's so many things that fall outside of what we can scientifically and prove and have an evidence base for. And there's also regulatory challenges with that. And we would really encourage that we promote treatments that are within those regulations and evidence base. But of course, there is a philosophy to pain as well, and we cannot discount that at all. And we absolutely keep an open mind and as much as we can. But I see Kirsty had her hand up there. Kirsty?
Yeah, no, I did, but then you ended it so eloquently, Joe. I actually didn't want to jump in because I was sat here thinking exactly what you were saying, that it is to each their own. And if some people find something that works for them, that works for them. But in terms of recommendation, of course we have to go along with evidence-based recommendations, and that can only be backed up by rigorous scientific process. which isn't to take away what someone says is working for them, but actually ensuring that recommendations are only evidence-based is so crucially important when we're considering the different cultural medical systems.
Also, when we did our patient survey, a lot of people did tell us in that they were using complementary and alternative therapies to help support them. Sam.
Yeah, if I can just come in on that. In the second survey, which I said was about pain medicines, we did slip a few questions in about non-medical treatments. And I can just read out one set of answers. 46% of respondents had used acupuncture or acupressure. 41% had done yoga, tai chi, or meditation. 39% were using self-management approaches. 39% were using exercise programs. 8% used hypnosis, and 3 used virtual reality scenes as well. And also there was a reference at 15% had used Chinese, Indian, or other ethnic types of medicine as well. So they're very prevalent.
Exactly. Tim.
Yeah, plug the Philosophy and Ethics Special Interest Group, which is part of the British Pain Society, notwithstanding the need for rigorous evidence-based scientific approaches, begins every day of its 3-day Rydal Hall retreat in the Lake District, which is coming up at the end of June, beginning of July, and there are still places available if anyone would like to book, with either wild swimming sessions in Rydal water, followed by Tai Chi on the lawn, and last year's expert speakers spoke about acupuncture as a way of dealing with chronic endometrial pain, and we had a very eloquent and scientifically based lecture on the subject of using hypnosis for pain control in cancer surgery. So it's a broad church, and they are nothing if not open to the full range of pain control options.
Yeah, good plug, by the way, Tim. Nicely done. I think we just got time for one more question. And the question is, will the patient platform be also including people now living with persistent pain after cancer treatment? Does anyone want to take that question? Sam.
Well, this is tapping into my area of work for many, many years. We're now recognizing that pain doesn't stop with the surgery. And, we know the majority of pains after surgery for cancer or other conditions will stop within the first 2 or 3 weeks, or within 3 months. But there is a tail end of people who have long persistent pain either from the original cancer, because it's, for instance, damaged bones, or from side effects of treatment, such as post-surgical pain or post-chemotherapy for cancer, neuropathic pain. But then there's another group of patients who those pains subside, but actually, and this may happen 5-10 years later, people who've had large doses of radiotherapy, we then see people coming back with damage to their organs, for instance, in the bowel. We've done a study recently showing the amount of bowel problems that patients have after pelvic radiotherapy. For prostate cancer, could happen after gynecological cancers. So the answer is yes, we're very alive to chronic pain in people with cancer. It doesn't just end with the treatment and, oh, you're a survivor, great. But actually, the person surviving with cancer is just keeping head above water sometimes because of the pain, and not just pain, but other symptoms that they're living with. Now, that is very much on BPS agenda.
Thank you. And I think that's all we have time for this evening. So thank you for coming today and taking the time out to listen to our webinar this evening, but also a very special thanks to all of our speakers this evening. And thank you for taking the time out, as well as thanking the EPIC committee as well for all of their hard work behind the scenes in getting this committee in and the BPS agenda for patient-centred care. And so thank you very much to you all, and hopefully we'll see you at either Rydal Hall or the ASM, another plug there. So good night to everyone, take care. Thank you all, bye.